little bit about him. Dr. Singh is a board-certified oral and maxillofacial surgeon and a member of the prestigious American College of Surgeons. He attended the University of Pittsburgh, where he graduated magna cum laude, obtaining a Bachelor of Science in Neuroscience with a minor in chemistry. He continued his education at the University of Pittsburgh School of Dental Medicine. He completed his specialty training in oral and maxillofacial surgery from Virginia Commonwealth University Medical Center, where he was trained in simple and complex implant surgery, as well as bone grafting, orthodontic surgery, pathology and reconstruction, and maxillofacial trauma. Dr. Singh is the vice chairman of head and neck surgery at UPMC Passavant Hospital and has a faculty appointment at the UPMC Department of Oral and Maxillofacial Surgery, where he participates in maxillofacial surgery trauma call at UPMC Presbyterian, Mercy, and Children's Hospitals, working with and mentoring resident surgeons. He is on the executive board of a local nonprofit group called Every Child Incorporated, and serves as president of the University of Pittsburgh School of Dental Medicine Alumni Board. Dr. Singh is based in Pittsburgh, Pennsylvania at North Pittsburgh Oral Surgery. Dr. Singh has a great case and presentation to share with us tonight, so let's welcome him now.
My purpose this evening is to present a case that I had the privilege of treating. I also wanted to point out that it utilizes the full scope of oral and maxillofacial surgery as well as dental implant surgery. My disclosures: I recently became a consultant for ZimV. Again, I want the implant daddy #2 jersey that I was promised from Zimmer. Did my training at Virginia Commonwealth University, where I had the opportunity of practicing full scope oral maxillofacial surgery. Got the chance to see a little bit of everything, whether it was common and uncommon, and was able to integrate into this practice a full arch immediate load workflow. So we'll discuss the following learning objectives, and hopefully along the way I will tell you a little bit about myself as well. We've all heard about the advantages of implant-supported prostheses, maintenance of bone, vertical dimension, and the ability to reduce the size of prosthetic. A lot of folks want the ability to taste food and are very hesitant to have a prosthetic that covers the palate. So just briefly, to make sure we're on the same page, we're discussing a fixed hybrid, which by definition is an implant-supported prosthetic that incorporates components of a conventional denture, crown restorations used to replace teeth, soft tissue, and bone defects. Other names for it: fixed detachable, all-on-X, profile prosthetic, screw-retained implant-supported prosthesis. In this particular case, we're going to be discussing an immediate load, which by definition is within 1 to 7 days of the implant. In my practice, it's the same day, which generally is 24 to 72 hours. Early loading is within 2 months, and conventional loading is after a minimum of 2 months. So we're going to briefly discuss some surgical considerations for these types of cases. I don't know about you guys, but oftentimes when I'm talking to the patient and I'm telling them you're doing fine, oftentimes I'm giving myself a pep talk just to ensure that Dr. Singh is doing a good job and reinforce that. Self-talk is great. So we're going to jump into maxillary considerations for surgery. So when we look at maxillary considerations, we want to consider the arch type, hard tissue, which would include bone type and architecture, planned tooth position, the type of defect, and the amount of bone reduction necessary for said prosthetic, soft tissue, lip support, smile dynamics, attached tissue present, anatomy, number of implants, and implant locations. That's a very common question. I'm hoping to demystify that. So generally speaking, from Mish's book, a Pittsburgh guy, folks that come in with a square arch form have the smallest anterior cantilever canine implants are sufficient for anterior support, and additional implants at the bicuspid or molar sites, pending the sinus position and bone availability, are ideal. So in this type of case, you have a small anterior cantilever, which is great. You don't need anything anterior to the canine, and you have good support of a fixed prosthetic. An ovoid arch form, which is the most common arch form that's present, has a slightly larger anterior cantilever. Therefore, you ideally want to place one implant anterior to the lateral or canine position. This prevents rocking of the prosthetic. Again, canines and molars are key implant positions. It's going to depend on your bone availability and your anatomy and sinus positions. And this is in the maxillary arch. Your tapered arch has the largest anterior cantilever. So these are going to be candidates that want and need more implants to avoid destructive forces and large cantilevers to violate what's known as normative values for AP spread. 4 implants anteriorly to counteract the large cantilever in this particular diagram. And again, additional implants pending sinus position and bone availability. So everybody knows that there's 4 types of bone, D1, D4. D1 bone is your hardest, strongest bone. Anterior mandibular cases are immediate load cases all day, every day. And then you start getting into the weeds with type 3 and type 4 bone, typically in the maxilla, typically in salvage cases, typically in the posterior maxilla, or compromised sites. So there are ways to do it. And yes, we have loaded those types of cases, but you just have to be very cognizant about treatment planning those, and you need to be aware of how to follow sound surgical principles. Ideally, you want to under prep the osteotomy in cases where you have D4 bone, which I'll touch on later. With the TSV implants, it was a very fine balance between under prepping 1 to 2 drills. With the new TSX implant, I have full confidence in placing that implant under prepping 1 osteotomy. And the surgical drill sequence is very streamlined, as I'll point out to you. So, an important part of treatment planning is your cone beam CT scan. It helps evaluate the bony anatomy, the architecture, and it helps you plan implant placement. So, oftentimes, you're going to want to angle implants in a graftless approach to avoid entering the sinus and doing any sinus lifting. All the literature bears out that sinus lifting, you can immediately load those, or you can load those prosthetics, but it may not be an immediate load prosthetic in that circumstance. Another important consideration is looking at the existing tooth position. It gives you information about the existing vertical dimension, the occlusion, phonetics, and aesthetics. The patient has an opportunity to tell you what they like, what they dislike, and it can also help you determine the implant position, the form of the surgical guide, and I'll kind of touch on this a little bit later. So in the white line in this diagram, you'll see the ideal tooth position or the tooth setup. That is super critical before you tackle these cases as a surgeon. You want to make sure you know where you're going before you start that journey. I had mentioned that profile prosthetics or screw retained prosthetics give a component of teeth, soft tissue, and bone. Perel indicated classifications of the edentulous maxilla. Tooth-only defects, where you have ideal soft tissue and bony structure, are better suited for crown and bridge implant, retained crown and bridge. Composite defects, which is the case that I will show you, in a patient that has good lip support, a fixed hybrid prosthetic is the ideal prosthetic. Places like Clear Choice and these other corporate entities have a square peg and a circular hole. They try to fit everybody into the category of being a candidate for a fixed prosthetic. That's not the case. If they have poor lip support, do not give them a fixed prosthetic. They will be very unhappy. Ways to determine what type of defect you have. A quick and dirty way of doing that is in an edentulous patient. If you have that final tooth setup in the form of a denture, you can replicate that or duplicate that in the form of clear acrylic. And then you can seat that prosthetic in the patient's mouth and have them occlude. On the left side of the screen, you can see where the red line is. There's no space between the cervical portion of the tooth and the edentulous ridge. The data that I gathered from that photo is that it is not a composite defect. It is a tooth only defect. And this patient, looking at their thick gingival biotype, would be a good candidate likely for crown and bridge on implants. That being said, you also have to look at lip line and smile dynamics, which I'll touch on the next screen. On the right side, you can see there's a very sizable composite defect here. So you're missing soft tissue, you're missing bone, as well as the teeth. So in this particular photo, the two red lines indicate what is missing from the edentulous ridge. This patient may be a candidate for an overdenture prosthetic or a fixed hybrid prosthetic, depending on the smile dynamics and the lip support. If the patient is edentulous, it's important to evaluate where the transition zone is between the prosthetic and the tissue. If it is visible on an exaggerated smile, this needs to be hidden by either performing a bone reduction prior to implant placement or designing the prosthetic such that it is not visible. Cone beam CT scan is very important for the treatment planning. You must balance bone reduction with the amount of bone that's available in the arch for implant placement. A preoperative evaluation of the cone beam CT scan will help with this, and also understanding the literature and stating that the minimum implant length that is desired for an immediately loaded prosthetic is 10 to 12 millimeters. So if you're needing to do bone reduction for implants that are going to be mini implants or 6 to 8 millimeter implants, this may not be the right candidate to do an immediate load prosthetic. Then you get into the realm of talking about milled bars and things of that nature, which is beyond the scope of this talk. Also very important for the restorative doctor and the surgeon to realize is you need to create adequate restorative volume and space that accommodates the implant restorative components. Abutments are roughly 3 millimeters. A hybrid bar is about 3 millimeters. Acrylic is 4. Teeth is 4. Generally speaking, in my head, the way I look at it is a zirconia final prosthetic is going to be about 10 to 12 millimeters of restorative space required from the incisal edge or the tooth setup or the anticipated incisal edge. As you see on the bottom right of this slide, the surgical guide or the anticipated tooth setup with the ideal phonetics aesthetics plays a crucial role in determining where that bone reduction is. You'll also notice that in this bottom right photo, there's a flange in the back, but also the front is very flat. They've indexed the amount of bone reduction required. So once the teeth go away, you actually have a landmark to determine how much bone reduction is needed. Again, it's demonstrated here. There's slots. So for a lot of my restorative doctors that I work with, one of which who's on this call, Dr. Michael Chapman, a lot of cases I do with, he and I have an understanding that when you provide the surgical guide, the final tooth position is prescribed in that. We utilize digital pressure, and there's slots on the palate or in the lingual to ensure that the implants are in a restorable position such that access holes are not going through the incisal or facial aspect of the final prosthetic. Also, if you look at the left edge of the photo, you can see that there are grooves in that guide where I go ahead and use my favorite instrument, a number 2 Ticonderoga pencil, the most important tool in my armamentarium on the upper left. I place the surgical guide and I use a pencil literally to mark that. I take either a Fisher burr or a reciprocating saw or a football burr in this instance, and I perform the bone reduction back to that line to ensure that we have done the appropriate amount of restorative space preparation. On the bottom right, you'll notice that's the final product. A lot of folks are doing guided cases, with many different implant companies and, laboratories. My one caution to doing that is certainly if you plan the case with teeth, anticipate the fact that you will fracture interseptal bone no matter how good of a exodontist you are, and you will also inevitably compromise buccal bone. So just be cognizant that there's troubleshooting that's involved. Whoever is loading the denture, your restorative doctor, should be comfortable with troubleshooting these things, and also understand that a lot of these stackable guides with bone reduction create 90-degree edges, much very similar to what you're seeing in the bottom right here. I typically take an extra few minutes to bevel those and contour those back, particularly in the maxilla on the palatal side, right by the tuberosity. That's a frequent sore spot, and that's a frequent place that gets neglected. Make sure you get back there either with your football burr or a hand file to make sure that's smooth, because the last thing you want is a patient with a loaded prosthetic and you can't get to a sharp ledge of bone. So I spend a lot of time doing this, much to my staff's chagrin. Again, there's many ways to do this. The alveolectomy, as I call it, can be done with a reciprocating saw, which we use in orthognathic surgery and reconstructive surgery, a fissure burr with facilitation of osteotomes, a football burr. My favorite method, which I call the hurling your cookies method, is when we simply take the full thing out in block and set it on the table. My staff hates when I do this, and that's exactly why I love doing it. We talked about soft tissue lip support. This is very critical when you're treatment planning for a patient. You certainly don't want to give an 84-year-old woman who has minimal lip support with her existing dentition or her existing denture a hybrid prosthetic, because her 84-year-old aged appearance that's gaining lip support from that and reducing circumoral ridges or wrinkling. They're not going to be very happy when their face is sunken in more from a flangeless prosthetic. So you want to choose very carefully who you do these cases on and make sure that additional lip support isn't needed. If you have somebody that's a dentulous, there's a couple ways you can do that. If they come with a denture, hold up a mirror, make sure they're happy with the aesthetics of that and how the lips look. If they don't have a denture, you can simply take a dental mirror, flip it such that the mirror side of it is facing the outside, and you can see if they gain additional lip support and the circumoral wrinkling is gone. Or if you're lucky enough to work with great restorative doctors like I do, they can give you a clear acrylic guide, or they do this part for you. They seat that clear acrylic duplicated guide in the mouth and make sure that the aesthetics are good before we get to surgery. Talking about surgical considerations, anatomy. So, in folks that have very thin alveolar bone, oftentimes we dissect such that we can visualize the nasal floor, we visualize the posterior maxilla, we mark where the sinus is, which I'll get to. Ole Jensen published a very useful and interesting article on how to circumvent situations where a patient has very minimal bone between the nasal cavity as well as the sinus. We refer to it as an M configuration. Ultimately, you can utilize the wealth of bone that exists between the nasal floor and the anterior wall of sinus by simply angling the posterior implants 30 degrees to draw out of the second, ideally the second bicuspid or first molar position, and the anterior implant can be angled about 30 degrees anteriorly such that the head of the implant exits from the near the canine or lateral incisor position. Identifying the maxillary sinus in maxillary surgery is very key. There's multiple ways to do this. What I have found is utilizing either Panorex or cone beam tomography. You can look at an edentulous upper arch and simply look at your Panorex and identify the fact that you draw a perpendicular line from the anterior wall of the sinus down to the opposing dentition, and you know that the anterior wall of the sinus lines up with the buccal cusp of the first bicuspid. So you know that if you're going to do 15 or 30-degree angled implants to increase your anterior posterior spread, you know where that anterior wall of the sinus is. Additionally, if you place an angled implant anterior to the wall of the sinus, there's several advantages to doing that. You can take a graftless approach where you do not have to subject a patient to bilateral large sinus lifts, which require 4 to 6 months of healing, followed by implants, which also require 4 to 6 months of healing, depending on what you ascribe to. So the third advantage of doing that is you increase the bone to implant contact surface area. So if you think of the implant, it's engaging bone crestally. It's also engaging the walls of the sinus. And sometimes, if the implant is long enough, you're actually engaging the lateral wall of the nose. So you have tricortical stabilization, which is great for initial primary stability, which is a very key factor in immediately loading a prosthetic. Different ways of identifying sinus, again, looking at your imaging, doing measurements. The right-sided screen is transillumination. If you want to have a disco party, turn the lights off, get a dental light in there, and as you can see, the hollow cavity of the sinus is visualized, and you can certainly mark that, again, with my favorite instrument, a number 2 sterile pencil. The incisive canal also comes into play in certain patients. I routinely identify that prior to implant placement for several reasons. Patients who are becoming edentulous obviously lose their proprioception. So the incisive foramen or fossa and the neurovascular bundle is simply not useful. You're not going to lose any vascularity. You have axial pattern of blood flow to the palate, as the OMFS guys on this call who have done any cleft palate surgery understand. There's collateral circulation from the periosteum and the adjacent soft tissue. So if you need to place an implant in the incisive foramen, say you have an ovoid arch form, you need one anterior implant, that's okay to do, but using your CBCT scan, you need to ensure that there's not a widened canal, because very rarely, but this can happen, the implant can be displaced into the nasal floor. So you can use it. It's not ideal, but it is there if you need it. The common question, how many implants and what's the position? So looking at the patient, in the maxilla, typically 4 to 6 implants. It varies based on arch form, anatomy, patient factors. Are they a smoker? Are they immunocompromised? Do they have periodontal disease? What type of AP spread do you anticipate when you plan this case on your CT scan? Also, 4 implants, as Brandmark and Palomalo coined through Nobel, the all-on-4 is a time-tested and proven method. But I think there's also some merit to evaluating the literature and looking at the patient. Again, a lot of these corporate chains push it, quote unquote, all on X or all on 4, and the patient may not be an appropriate candidate for that. If a patient, certainly more implants is better, but you also want to be mindful of the patient's financial situation and what's best for them long term. I'm not going to graft somebody only to take a reciprocating saw and cut all of that bone out. I think that's not right. And so, in a graftless approach, I think that utilizing axial as well as tilted implants up to 30 degrees is ideal to maximize your AP spread. You also want to not lose focus of what's going on in the opposing arch. Is there signs of attrition? Do they have a heavy bite? Are they bruxers? You want to take the full concept into effect. So this is a traditional all-on-4. 4 implants in the maxilla and the mandible. You can see that in the maxilla and the mandible, 3 of the 4 implants are angled at 15 degrees. The bottom right one is angled 30 degrees in order to increase AP spread. You're also utilizing axial implants for axial loading. I didn't include the literature, but there's literature replete with evidence that tilted implants versus axial implants, if done following proper surgical procedure, is valid. In this particular case, the patient had a heavy bite, they had a square arch form, and therefore decreased AP spread. So we decided to do 6 implants on this patient. As you can see, the distalmost implants skirt the anterior wall of the maxillary sinus. There's tricortical engagement, engaging the lateral and inferior walls of the nasal floor, and they ideally exit through the first or second bicuspid location. This was a delayed load case. So we're going to discuss a lot of very similar things. So I'll kind of breeze through this as far as surgical considerations. So again, the same thing. In the mandible, you need to look at hard tissue, soft tissue. The anatomy is obviously a little different. You have the mental foramen and nerve. You have the inferior alveolar nerve position, genial tubercles in some patients, and then also looking at the number of implants and implant locations. So we all know D1 bone, sometimes D2 bone in the mandible. I love immediately loading mandibular cases, and I think most folks do. In this particular case, this person had an atrophic mandible. Certainly, there was a lot of considerations. My incision design was altered due to the fact that the resorption was so severe that the inferior alveolar nerve canal was actually resorbed. So I modified my incision design as to not transect the inferior alveolar nerve here. Some cases, not in this case, but in some cases, it's not uncommon to put your finger under the chin and actually have your implant drill go transmandibular through the inferior border of the mandible. I don't recommend that. It's published in the literature. I don't recommend that because then you get into a consideration where you're introducing soft tissue flora to the oral flora and predisposing a patient to infection. Again, tooth position, smile design, very important. Restorative space we discussed at length, very important. You want to make sure you have adequate keratinized tissue. You want to make sure you have enough restorative space. The problem with not doing enough bone reduction or opening the vertical dimension of occlusion in patients who don't need it is you predispose those patients to temporal mandibular dysfunction. You also risk fracturing your prosthetics. So say you have a double arch patient who has zirconia over an acrylic mesostructure with a metal substructure. They're going to continue to crush that acrylic, and you're going to be spending a lot of chair time, and you're going to be cursing your surgeon's name. Obviously not me, because I'm going to do enough restorative space, but whichever surgeon you use that doesn't respect this, you're going to unfortunately deal with the consequences of that. So very important to make sure that you leave enough restorative space. On that same topic, materials are very important. Zirconia requires a little bit less restorative space. Acrylic wrapped with a metal substructure does require a little bit more restorative space in the tune of 12 to 15 millimeters, whereas zirconia, you can get away with 10 millimeters, even up to 12 millimeters. When you're exposing the mandible, respecting anatomy, you want to make sure you don't strip the mentalis muscle. It's very important to expose the full mandible, but you also want to make sure you don't strip the mentalis muscle. This is what's called a witch's chin deformity. For the OMSs on this call, we know this very well from our boards and when we do cosmetic or elective genioplasties for orthognathic surgery or simply treat a symphyseal fracture. We always take care to bisect both bodies of the mentalis muscle and resuspend it. When you're going through a crestal incision and a intraoral dissection, you want to make sure you don't strip off those muscle fibers because the mentalis muscle will not reattach itself, and you'll end up with a person such as this person in the photo who has kind of a sharp chin point and what's called a witch's chin deformity. Additionally, during surgery, I routinely identify and protect the mental nerves. You want to plan your dive and dive your plan. You want to utilize your cone beam CT scan to ensure that you know the position of that, and then clinically that matches that. So in this particular case, I identified it, I protected it. It's also important to note that in 12% of mandibles, there's an anterior loop to that mental foramen. So what happens is the mental nerve actually transfers itself, or the path of it goes about 5 millimeters anterior to the foramen. So the reason this becomes important, as you can see in the top left photo of this CT scan, is that you have to respect that anterior loop. So say you're wanting to tilt an implant 30 degrees to increase your AP spread, it behooves yourself to give yourself a 5 millimeter buffer zone. On the bottom left, that's from Michael Block's book on implant dentistry. He also acknowledges and appreciates and recognizes that that's a real thing. You can see it on the CT scan, and you need to respect it. Again, inferior alveolar nerve position. Oftentimes, we do interforaminal implants for hybrid patients because posterior to that anterior loop of the mental nerve, they have a pretty sizable vertical and horizontal defect such that axial implants are not always possible. It's always a good day in the office when I can place 4 to 6 axial implants in the maxilla or the mandible. Unfortunately, life isn't always what you plan, so you need to have a backup plan. So in this particular case, it's important to note your distances in the first molar, second bicuspid position to see if an axial implant is possible. Or you need to have a backup plan if you're planning on tilting your implant 15 to 30 degrees, if you run into anatomical defects or things of that nature. You want to have a backup plan to be able to load that prosthetic, or at least give the patient teeth that day. None of my patients leave the office without teeth the same day. Genial tubercles, these are also high pucker factor cases. Severely resorbed mandibles, sometimes when you're exposing the mandible, you'll identify the genial tubercle as being higher than the actual crest of the ridge. I love genial tubercles in the sense that there's a wide body of bone that I'm able to place an implant in. However, you need to respect the genioglossus muscles and genial highway muscles, which if you detach those from the genial tubercle, excuse me, you can predispose a patient to obstructive sleep apnea. So it's important to understand, recognize, and appreciate it's there. If you're going to use it, make sure you use it well. I'm a Marvel Comics geek, so I'll tell you, with great power comes great responsibility. Again, implant number and position. You're looking at D1 bone here in most cases, sometimes D2 bone. Oftentimes you can get away with 4 implants, but again, look at the opposing arch, look at the patient as a whole, not just a single arch, and see what they have going on. What type of arch form do they have? Is it square? Is it tapered? Is it ovoid? Do they have signs of bruxism? Are they a smoker? Are they immunocompromised? Again, the literature is replete supporting tilted implants. There is such a thing as too much of a good thing. If you tilt it beyond 30 degrees, the multi-unit abutments that are out there, whether you use ZimV or another implant product, that you need to be aware of what the system is and what you're utilizing. So if you place a 45 to 60 degree angled implant, number one, I congratulate you because that's very impressive. Number two, I will scorn you because you shouldn't be doing that, because no multi-unit abutments go that far. So if you're tilting an implant more than 45 degrees and expecting to load it with good results, you're going to burn yourself, and you're going to burn your bridge with your restorative doctor. I want to pivot into the second point. So, God bless my local reps, because I had been hollering at them about having and designing a better implant for immediate load solutions. So in this section, I want to touch base on the implant design and compare it to other implant designs and do a very brief literature review. So the TSX implant is a game changer, as you can see from this beautiful photo. Has a more aggressive thread pitch, single threaded, which can give you more initial implant stability. So the TSX implants exceed expectations, as the text states in immediacy, and give you a good combination of clinically proven features. So what that means is a quick overview comparison of the TSV versus the TSX implant. Our practice places a lot of TSV implants, and I've certainly loaded the lion's share of my cases with TSV implants. But the TSX implant was a godsend. With the TSV implant, it's a tapered implant, which is great, as is the TSX implant. All of the literature supports that a tapered implant is ideal for immediacy. The difference between the TSV and the TSX implant is the only uh, level of platform switching was at the 3.7 and 4.1 diameter. So a lot of us on this webinar know that platform switching is very important for crestal bone maintenance. So if I put a 4.7 diameter implant in there as a TSV, there's no platform switching available. So that's okay. It doesn't mean that we're going to lose crestal bone necessarily. It just means that I'm going to countersink that implant 1 to 2 millimeters in anticipation of or in preparation of potential crestal bone loss. And also, I'm going to take a diamond round burr and relieve the area distal to the implant head to be able to passively seat that multi-unit abutment for my restorative doctor. The threads are tapered. Passive triple lead thread designs. They do have apical cutting ability, which is good and bad. It's bad when you've prepped an implant to 10 millimeters and you're torquing the implant down and it's binding a little prematurely. 3/4 of the way in, then you get down to the 10 millimeter and you keep spinning, and then you lose that initial implant stability or torque. So you can actually bottom out and lose that primary stability. Again, I've done many immediate successful implants, single units, multi-units. I've done immediate load. I'm not saying the TSV is not suited for this, because it is. But again, the TSX takes the guesswork out of it. So the TSX implant is a tapered single thread implant design with a more aggressive thread pitch. It's a dual acid etch collar, which is different from the TSV, which had micro threads crestally and was a machined collar. It also offered The TSX also offers platform switch capabilities at all diameters. There's no self drilling capability, so you look at that rounded apical portion and you see that it's not going to self drill or go into another area. It's going to follow beautifully your osteotomy design. It's going to torque in, it's going to glide right in and maintain that primary stability. There are other implant systems out there that I have used. Full disclosure, biggest comparison is, let's say, the Nobel Active implant. That's a double-threaded, aggressive thread pitch. There are pros and cons to it. The biggest con in my hands is you can actually do damage. You can fracture bone if it torques in too tightly. You can create microcompression and future necrosis, which is a delayed failure of the prosthetic rather than an immediate failure. So you get those 50 to 70 Newton centimeter torque values, but you don't realize how much damage you're doing by micro compressing the trabecular bone and even devitalizing that bone. Just a quick overview of the TSX versus TSV performance indicators. You can see on this very beautiful bar graph that in an extraction protocol, ideally greater than 35 Newton centimeters of apical torque is ideal to load an implant. The different colors indicate the different apical torque values between the TSX and TSV implants, and its magnitudes are different, and the standard deviation is pretty sizable and pretty impressive. The other thing that's important when you're considering using this implant or any implant is the drill sequence and following good surgical technique. If you're prepping your osteotomy, especially in dense bone, you want to use a lot of irrigation. My nickname in the practice is Scuba Steve because I utilize bags and bags of fluid because I don't want to overheat the bone. Um, Above 47 degrees Celsius is where you start to get bone necrosis and bone overheating. So you want to make sure you have adequate cool saline irrigation. You also want to make sure you're doing a quick and precise pumping motion as you're prepping your osteotomy. If you're leaving the drill within the bone, within the osteotomy without pumping up and down, it's very unlikely you're getting the irrigation apically. It's very unlikely that you're under prepping the osteotomy. And I've been guilty of all these things. That's why I'm telling you. Um, and it's very unlikely that you're going to get primary stability, especially with a TSV implant. So you want to make sure you're like an implant ninja. The drill is in and out. You're doing pumping motions, get good irrigation in there, and make sure that you're following the surgical protocol. With the TSX implants, as you can see, most of these protocols are 4 to 5 drills depending on the density of the bone, which is great. So that creates less error. So oftentimes I'm not drilling all of my step drills. I'm skipping the step drills and going sequentially until I'm under prepped 1 to 2 drills, depending on the quality of bone. So again, talking about implant design in sort of supporting the TSX design. It came out at the right time. It was very well designed, very well researched. Um, in this particular study, in the Compendium of Continuing Education in Dentistry, published in 2020, the key takeaway points were primary stability were a function of mechanical retention of the implant of the bone, which is greatly influenced by implant design and the density and volume of the osteotomy. Additionally, primary stability can be improved by underprepping the osteotomy and using narrower drills and wider tapered implants. So the advantage of the TSV and TSX is they're both tapered implants. Um, Surface texturing contributes to initial primary stability. The TSV implant, probably 6, 8 years ago, everybody was on the train of micro threads at the collar for soft tissue attachments and maintenance of crestal bone. Since then, and empirically and in the literature, that's been disproven. Um, Hence why I countersink implants that I'm going to immediately load because those micro threads aren't doing anything. If you get bone dieback, you actually, in fact, have more problems because those micro threads are going to act as traps for food, bacteria, plaque, and biofilm. So if I see a salvage case where somebody else has done the implants and threads are exposed, my first move is to take a diamond burn and remove all of those threads. With the TSX implant, it's a dual acid etch. The literature bores out that a roughened surface acid etch or a spray titanium spray blasted textured implant is ideal. TSX has all of that. The implant surface texture, as we touched on, also is important for bone to implant contact surface area. So, for example, in sites with poor bone quality, implants with the acid etched surface can achieve a higher BIC than machine surface. Surface roughened implants have a failure rate of 3.2%, 5 times lower than machine surface implants. Um, This can be done in the maxilla as well. A lot of folks are hesitant to do so. This is one of many studies that I found, but all the same principles apply. You need to have good patient selection. You need to have proper surgical technique, which includes underprepping the osteotomy, avoid overheating the bone and pressure necrosis of the bone. There is such a thing as over torquing an implant. And you need to achieve proper BIC. Proper BIC can be achieved by implant design selection, length, and width. Wider, longer implants, historically speaking, are better. Um, implant design, as we discussed, tapered, wide, roughened surfaces allow for that initial primary stability and right off the bat, good BIC. Um, so we talked about longer and wider implants. It's not always the size of the boat, but sometimes it's the motion in the ocean. And so you're going to hear an oral surgeon talk about occlusion and prosthetics, which is totally crazy, but I'm going to go ahead and go for it. So when you're looking at the prosthetics, you want to look at the arch form, you want to look at the incisor positions. Again, all of these concepts, I keep hounding them because they're very important. The lip line, the smile dynamics, vertical dimension, the existing and planned occlusion, and anticipating AP spread and cantilevers. Um, Very basically, know your system. You need to know what to torque the prosthetic screw at. You need to know what to torque the multi-unit abutment at. You need to know how to torque your comfort caps on, your temporary cylinders if you're doing a chairside conversion. All of these are very important to know ahead of time. Again, I've made these mistakes. I'm not going to belabor the point, but consider your arch form when you're designing the prosthetic and you're planning the implant case. Be cognizant of the fact that the ovoid form is the most common form. The square arch form is more common in the maxilla due to resorption of the premaxilla. Tapered arch form, generally speaking, is the most common. The square arch form is going to allow for shortest AP spread, and the tapered arch form allows for the greatest AP spread. Incisor position is also very important. So for my OMS guys that are on the call, when we look at patients for orthognathic or corrective jaw surgery, we look at a lot of these same parameters. So we have the patient in repose, as is shown in this photo. We look at the lip to tooth that's visible. It gives a youthful appearance, reduces the lipstick lines or the peri-orbital or peri-oral irides. Um, it's not always achievable to reduce those again with a fixed hybrid prosthetic without a flange. Generally accepted to have 1 to 4 millimeters of incisal show at rest. The other thing that I have patients do is I have them smile. And then I tell them, okay, now really smile. And then they smile a little more. Then I tell them a cheesy dad joke and I say, smile like you won $1 million in lottery. Show me as much tooth and gum as you can. The reason I do that is Joe Schmo, who comes into the office, who's had this procedure done, isn't going to do his normal smile. He's going to put his finger in the vestibule and show how 3 millimeters of pink acrylic is visible at the transition zone. And Joe Schmo is going to say, Dr. Singh, why is this here? Why does this keep happening? And I'm going to say, Joe Schmo, stop doing that. Stop putting your finger in your mouth because that's not how you smile, right? So the incisor position is key because it gives you lip support. It's visible in repose or at rest. And the incisal guidance angle is important consideration in the occlusion. So you want to make sure that you have, if you're immediately loading a prosthetic, which I'll get to in a beautiful 1 or 2 slide summary, you want to make sure you have posterior disclusion. You want to make sure there's no posterior interferences when the patient's going in protrusive movements. You want to make sure that there's no destructive contacts or shearing forces on those implants. The incisal guidance angle must be steep enough to allow for posterior disclusion. It also uh, you also need to ensure that the mandibular anterior teeth contact the lingual surface of the maxillary teeth in maximum intercuspation. In cases of class 2 deep bites, the VDO can be opened up to help achieve this. That's a good indication to open up in a collapsed bite, to open up the VDO to achieve this. Lip line and smile dynamics. Repose is at rest, smile, and animated and super animated smile. Again, ideal to show 1 to 4 millimeters of incisal edge at rest. This is variable due to the thickness of the lip, the age of the patient. Older patients tend to show less incisor in repose. So another big mistake that you can make prior to doing surgery is reducing the bone such that the transition zone is invisible and they have a saggy upper lip and you've put their beautiful prosthetic underneath that soft tissue drape of that upper lip that's already kind of migrating due to age and migration of muscles and facial fat pads. So be careful that you don't create a situation where a old patient looks older or a young patient is made to look old. You also want to avoid situations where you're creating long unesthetic crowns in a patient that has a thin upper lip and a hyperdynamic smile. You want to ensure that you hide the transition zone between the prosthetic and the natural tissue. Again, there's ways to identify this: a clear duplicated acrylic tooth setup, flipping a mirror to indicate if the patient needs lip support, things of that nature. You can do digital wax up. Technology is so great. You can do smile designs and digital wax ups at this point. Um, the vertical dimension of occlusion, as defined, superior inferior relationship of the maxilla and the mandible and maximum intercuspation. Generally speaking, obviously there's exceptions to this. You want to ensure that you reestablish this or minimally change this. It contributes to function and aesthetics. It's important to determine the ideal VDO pre-surgically. This impacts the aesthetics, the function, structural needs of the dentition. Aesthetically, it dictates the incisal position, occlusal plane, vertical dimensions and proportions of the face. A collapsed VDO can give a class 3 or a concave facial profile. Functionally, if the decreased incisal guidance is diminished, it can cause posterior interferences and destructive forces on that immediately or delayed load prosthetic. VDO can be altered to improve aesthetics and function, but you also want to realize that opening up a VDO does come with consequences. Again, great power comes great responsibility. You want to make sure you don't predispose this patient to temporomandibular dysfunction. Occlusion can be determined by the implant plan, opposing dentition, cantilevers, parafunction. 3 accepted occlusal patterns. I'm going to have you guys dust off your dental school knowledge, and we're going to get into a deep dive into different occlusal patterns. A bilateral balanced occlusion is when you have simultaneous anterior and posterior contacts in centric and eccentric position. A lingualized occlusion is a type of bilateral balanced occlusion where the lingual cusps articulate with the occlusal surfaces in the mandible in centric and excursive movements. Bottom line, you can use these in a fixed hybrid opposing a conventional denture, particularly in the instance of a hybrid in the maxilla and a lower conventional denture. I don't know why anybody would ever want that, but for some reason, if somebody wants that, you want to make sure that your fixed hybrid is not causing the denture to rock. You can also do this in a fixed hybrid denture opposing an overdenture. Just especially say a fixed hybrid in the maxilla and a 2 implant overdenture where it's both tissue and implant supported. You want to make sure that you're not rocking the prosthetic. So here's a brief schematic of what that looks like. Group function occlusion is great, especially in immediately loaded prosthetics, but you want to avoid and minimize the length of a distal cantilever. Very important. When you're counseling the patient on what their dentition is going to look like, you want to be very honest that their provisional prosthetic is not going to have third molar occlusion. You're going to at most have a bicuspid, maybe a baby molar occlusion, depending on the AP spread and what the patient presents with anatomically. You also, in this particular case, you get simultaneous contacts between multiple teeth on working sides, and you get during excursion and no non-working or balancing contacts. You get transmission of lateral forces to the posterior teeth and lateral excursive movements. I use this routinely in immediately loaded prosthetics in my very good general dentists, a lot of which were on this call. My buddy Michael Chapman knows this to heart. Fixed hybrid opposing a fixed hybrid, this is a good option. If the canine site is weak or compromised, this might be a good solution. And then there's what we call an immediate load occlusion, which has a minimized cantilever, simultaneous points of contact on all teeth on the working side. So you get disclusion on the non-working side. You get anterior guidance and protrusive, so that incisal guidance angle comes into play, and you avoid balancing contacts. So this is an example of what a immediately loaded prosthetic may look like. Um, What I would say in this is during protrusive, first of all, this patient's heavily sedated. Second of all, we did not design the upper prosthetic. It's loaded on a bunch of mini implants and it has a flange. But that being said, this patient was an absolute delight to treat. A general practitioner had placed a bunch of mini implants in the mandible. He developed an osteomyelitis as well as a submandibular abscess from the failed implants. After 6 weeks of IV antibiotics, NG tube for feeding due to difficulty with swallowing, speech pathology training, and 6 months of healing, we were able to remove the remaining mini implants and immediately load this on 5 implants. The patient's a little all over the place as I took this video immediately post sedation, and it's first time with literally zero proprioception with local anesthetic on board, as well as with an opposing prosthetic that's less than ideal. Now, that being said, I'll circle back to that video and I want you to pay attention to the excursive movements. So, admittedly, we left a little bit on the table with the anterior incisal guidance angle. This isn't wrong or bad because there's bilateral equal contacts posteriorly, but this is centric occlusion. And during excursive movements, you'll see right here as he moves his mandible to his right side. And as I get the good camera angle, you'll see that there's disclusion on the balancing side. That's the key takeaway point here. So you want to make sure there's no destructive contacts. A third occlusal pattern, a mutually protected occlusion. The anterior teeth protect the posterior teeth during protrusion. That's an incisal guidance angle, which was not present in the video I just showed you. It protects from shearing and destructive forces. You can use this in a fixed hybrid against natural, fixed versus fixed, or fixed versus an implant overdenture. I can tell you right now, don't often use this, but it is an option for those who ascribe to it. So this is the money screen right here. So if you want to screenshot it, or certainly if you want to reach out, I'm happy to help you with this. Occlusal modifications for your implant prosthetics. You want to make sure you have bilateral stability, a wide range of freedom in centric occlusion, a narrow occlusal table, minimal cusp height. You don't want a monoplane occlusion, but you also want to make sure that you're not creating such superior dental anatomy that you're creating more problems. You want to have excursive movements with working, without working and non-working interferences. So your implant protected occlusion developed by Misch, a Pittsburgh guy, was published and designed to reduce the biomechanical stress of the implant interface. So the takeaway points of what I just told you prosthetically and surgically: you want to utilize key implant positions, canine and molar sites. You want to increase your implant surface area, go long and strong on these, but it's also the motion in the ocean with the prosthetics. You want to make sure you minimize cantilevers when you're immediately loading a prosthetic. The ideal cantilever is 0. That'll come up in your quiz later. Don't tell Zimmer I gave you the answer. Concept, again, for Misch, a shallow anterior guidance angle. Every 10-degree increase you have leads to a 30% increase in force to the anterior segment. So again, you can't have too much of a good thing. You don't want to flare those anterior incisors out, dump them out, such that you're creating 30 to 60% more strain on the anterior implants. All patients, at least in their final prosthetic, get an occlusal guard. Some, such as the patient in this presentation, got one immediately. Patients lack proprioception. They have an increased biting force in a lot of instances, particularly with zirconia, fixed zirconia implants. They lack feedback on premature contacts, which will lead to biomechanical overload. It helps protect the prosthetics in patients with parafunctional habits. Everybody knows about AP spread and cantilevers. I'd be remiss if I didn't briefly touch on this. AP spread is defined the distance between a line drawn between the center of the anterior implant and the distal edge of the posterior implant. It helps dictate the allowable cantilever. The English rule for a quote unquote all-on 4 or all-on X prosthetic should be no more than 1.5 to AP spread. Generally speaking, in the mandible, 10 to 12 millimeters, in the maxilla, 6 to 8 millimeters posterior cantilever is allowable. Again, I'm going to tell you right now, have zero cantilever. If you want your implants to be successful, if you want the prosthetic to be successful in a provisional prosthetic, no cantilever or minimal. On your final prosthetic, the English rule and the Mish rule comes into play, and that's okay. Obviously, people want at least a first molar occlusion. So just a schematic that all of us have seen in dental school about the English rule. Um, so in summary, your immediate load guidelines are you want good AP spread. There are no true guidelines, but this is what I adhere to and what ZimV recommends for their implants. You also want to prepare the patient for the possibility of not being able to load the implant the same day. That's why I'm a huge fan of a chairside conversion or at least having a conventional denture such that the patient doesn't leave with nothing. Good implant bone volume around, or good bone volume around the implants rather, at least 4 millimeters of bone circumferentially per implant. At minimum, I like 30 to 35 Newton centimeters of insertion torque with these new or TSX implants. You can very easily achieve that without necrosing the adjacent bone. It's more critical to have good insertion torque on anterior implants than posterior implants. I would argue they're equally important, but just reciting what the literature states. Appropriate implant numbers and positions, appropriate occlusion, and make sure your patient's compliant. Make sure they're non-smokers. Choose your patient very carefully. As far as maintenance goes, all of my patients leave with a very detailed 4-page document on what they can and can't do. They get read the Riot Act at the pre-surgical appointment, post-surgery, at their post-operative phone call several hours later, as well as at their 1-week follow-up. Home hygiene is important. I use the analogy for a car when patients tell me or ask me if this is going to last forever. I ask them if their Geo Metro still is around. It's not, and that's for a reason. You need to maintain this. There's no standard protocol or guidelines for the American Association of Prosthodontists or the ACP, but certainly prosthetic screws, as we know, have prosthetic screw fatigue within 1 to 2 years. Do not take these prosthetics off when you see them a week out, a month out. In fact, just don't take them off ever. You have cross arch stability while the implants are integrating. Don't touch them unless there's some emergent issue. Talk to your surgeon and make sure that it's an appropriate time to do it. But you do not need to remove and replace the prosthetic. You're creating micro movement in that, and that's going to be destructive. Proxa brushes are key. All patients, I know Dr. Chapman gives all of his patients complimentary water picks. I educate them on Proxa brushes, things of that nature to keep that soft tissue healthy around the implant. So the coup de grace, we are in the final stretch of this presentation. Hope everybody's still there and paying attention. And if you are, God bless you. So this was an interesting case. I do want to point out that all photos in this presentation were obtained with patient permission and consent. Brian is a 34-year-old male truck driver who is driving. He's a Pennsylvania-based young man who's driving his truck in Texas. Someone who was a total jerk threw a rock off a bridge, which went through the windshield of his truck and created a comminuted and mandible fracture. He underwent 3 surgeries by an oral maxillofacial surgeon in El Paso, Texas, to try to repair this. 2 weeks after the initial stabilization, he presented with loose mandibular hardware. It was replated. He then developed a submental abscess, which was drained. The hardware again was loose. The hardware was reapplied. Multiple teeth were extracted. Um, and the patient was discharged and presented to my office 2 days before New Year's Eve because, of course, that wouldn't happen, when I'm sitting around twiddling my thumbs. So his problem list is staples in the neck, which is unesthetic, leakage of saliva from the mouth through the neck, so an orocutaneous fistula, a gross malocclusion. As you can see from the bottom photo on the left side, he's only occluding on the left side. He has mandibular widening, which tells me that the fracture, the symphyseal fracture, was not reduced appropriately. And that tooth is totally one on the right side. Those teeth are one full occlusal table outside of the opposing occlusion, and multiple compromised teeth due to the fracture. The top right photo is a aerial view of the hole from the mouth leading through the neck. Also showing vicral sutures there in an attempt to close that. We leveraged technology in this particular instance. We obtained a stat medical grade CT scan to evaluate the position of the mandible. You can see in the top photo that the condyle is seated on the left side. The teeth on the left side were in occlusion. However, the right side had no occlusion. You can see that the comminuted fracture created defects anteriorly, particularly in this symphyseal area where that orocutaneous fistula was. So we elected to take this patient to the operating room immediately. New Year's Eve. You can see the timestamp on the top right corner of the CT scan. We took the patient immediately, put him under general anesthetic, opened up the submental incision, removed the staples, accessed the fracture. We 3D printed a skull ahead of time and pre-bent a reconstruction plate to readapt to the ideal contours of the mandible. We compressed the fraction site to ensure good reduction, as is visualized on the bottom left side. We placed the patient into maxillomandibular fixation because the patient was a heavier set gentleman who had a square arch form, a heavy bite, evidence of bruxism. I did not want him to create micro movement, even though the plate was load bearing. Did not want to create micro movement or risk a chance of this hardware failing for a third time. This proposed its own unique challenges. In the maxilla, where he has a full complement of dentition, we utilized Stryker, what are called hybrid arch bars, which are permucosal and fixated into place through the bone. In the mandible, we utilized segmental, what are called Eric arch bars, which all the OMS guys on this call know what they are. Unfortunately, the patient only had two teeth on the left side. So right down here, you can see this wire. We used a circummandibular wire where we passed a wire around the inferior border of the mandible, made a percutaneous incision intraorally to pass that wire, feed it up to hook onto the lugs up on top of this hybrid arch bar. These are intermaxillary fixation wires to stabilize the bite. The patient remained in maxillomandibular fixation for 6 weeks. Technically speaking, with a restorative load-bearing plate or a reconstructive load-bearing plate, it's not necessary to do so. However, with this gentleman who developed multiple hardware failures and infection, I deemed it necessary to do that. He was on a soft non-chew diet for 6 weeks. We did an advancement flap to close that tissue. 6 months later, he presented to the office wanting a more permanent solution to his composite defect in the mandible. As you can see, stepwise, we flapped, we sedated the patient. We did a full thickness mucoperiosteal flap, maintaining the soft tissue pedicle that closed the orocutaneous fistula. So you can see a little bridge of tissue right here that we maintained throughout the surgery as to avoid recreating that defect. A para midline pin was placed in order to parallel the other implants. I typically center this over the opposing incisive papilla, or if they have a maxillary denture, to ensure proper positioning as well as symmetry of the implants. I use the clear acrylic guide that Dr. Chapman provided me with. the ideal tooth setup with a slot, just to ensure that the implant is drawing in a restorable position. We under prep the osteotomy site in this particular case. I think TSX was released literally 2 weeks prior. And I think my reps were getting my hands on multiples of these to demo this, to do this presentation. But we under prepped the osteotomy only by one drill to ensure we had proper primary stability, but we made sure that the implants didn't torque at 70, 80 plus Newton centimeters to make sure there's no bone necrosis. We placed the TSX implants. As you can see, it's a nice, clear, gliding motion. These implants were thankfully all axial. We then went ahead and placed the multi-unit abutments at the time of surgery. Dr. Chapman was present in my office. During this, we torqued them down to 30 Newton centimeters as prescribed by Zimmer. But we also, pro tip here is when you're putting on the comfort caps here, just use finger tight pressure. Yes, I have spun out a multi-unit abutment and an implant by over tightening these. These are temporary. They just allow for you to adapt the soft tissue around, and it allows for a chairside pickup if you choose to go that method. What I like to do to manage soft tissue is, I'm proud to say, a technique that was published by my residency alma mater, the transalveolar suturing technique to maintain vestibular depth, as well as to manipulate keratinized tissue following alveolar ridge reduction. So, as you can imagine, patients with teeth, you're reducing bone to create enough restorative space. On the left side of the screen, I'm utilizing a fissure burr. I'm drilling crestally from the crest through the lingual bone, creating holes on either side of the implant. On the right side here, I'm utilizing Vicryl or Polysorb sutures to first grasp the buccal tissues, the keratinized tissue. Then I'm suturing it through the crestal osteotomy that I've made. I'm then picking up the lingual tissue and cinching everything down. As you can see in this video, the tissue cinches down around those implants such that your restorative doctor is not fighting to pick up those healing caps or identify the implant positions. I teased some of my restorative colleagues that I've done these cases on that they've gotten a little aggressive with their pickup materials, and they've actually pulled sutures. That's why I make myself available to resuture as needed. So doing a traditional chairside conversion, in this case, we used a futar bite registration material to pick up the implant locations over the comfort caps, utilizing a traditional mandibular denture. It's a quick setting material. And it indexes the implant positions. This is a different case, but it demonstrates the point I'm trying to make. We take the traditional denture, we use a fissure burr, and we go ahead and index those positions utilizing micro osteotomies or holes in the denture. We then take a prosthetic football burr, open that up such that when those comfort caps come on and the temporary cylinders go on top of the multi-unit abutments, that implant draws very passively. You want to make sure that that prosthetic has a very clean entry and exit point and it's fully seated. The last thing you want to do is make sure there's rocking or anything like that, and make sure that you don't seat the prosthetic in an incorrect position. I was always taught to use a rubber dam, and that's a published thing. My good friend and colleague, Dr. Michael Chapman, utilizing products from Road Dental Laboratory, use this gasket and plug kit. So instead of fighting to put a rubber dam on, none of us like putting rubber dams on. Patients don't like it. In order to seal off and prevent acrylic from flowing into the surgical site, as well as at the intersection between the multi-unit abutments and the cylinders, you can utilize these gaskets and plugs in order to make sure that that acrylic doesn't seep into the surgical wound. Again, these temporary cylinders, you don't want to over torque them. Again, finger tight just to index the implant position. You're going to then backfill your cameo surface with Voco Quick Up or some self-curing luting agent or a quick curing acrylic material on a syringe. Again, in this particular case, we use Voco Quick Up to seal off these cameo surfaces around these gasket plugs. We then unscrew the whole prosthetic from the patient's mouth. We go ahead and place the implant analogs to then seal the other side, the intaglio surface of the denture. We then utilize the Voco Quick Up in conjunction with the hard denture reline material in order to mold it around those implant analogs. Once that has set, you remove it and you have cut off your temporary cylinders. You've sealed everything off. You then have a nice setup in your office that you can prosthetically polish and smooth this out. The key takeaway points here are on the intaglio surface. Placement of the implant analogs versus the rubber dam prevents lumpy texture where food can be caught. So you're filling in any gaps or voids where you have a convex surface and making it, or concave surface and you're making it convex. And then that's the prosthetic seated in the mandible. So we go ahead and seat that prosthetic. We utilize the one screw test to ensure a passive fit of the prosthetic and verify the occlusion. The one screw test is a test used to check the fit of a multi-unit screw retained restoration. Ultimately, you place a screw on the distal most implant, seat the prosthetic, make sure that the prosthetic is not lifting and there's no signs of things unseating. Once you've ensured that the screw fits in passively without altering the fit or shape of the denture, you go ahead and send home the rest of the prosthetic screws. You want to make sure that you leave enough space to make this cleansable. And you also want to make sure you take a radiograph to make sure that your multi-units are seated. We quickly recognized this was not seated. We went ahead and reseated it. On this Panorex, you can appreciate several things. One is the TSX, the beautiful radiographic design of this. Janet Carr, Craig Goldman, Paul Drennan, Steve Cafaro, Brad Lynn were all very excited when I first sent them this x-ray. You can see the beautiful platform switching. We identified that this is not fully seated. We can also see this reconstruction plate is in place. The mandible is not mobile before we did this. I know you can see a little bit of a gap here. That's because the site was a comminuted fracture. That's a soft tissue callus that can take about 6 months to fully calcify, even beyond. Patients get thorough postoperative instructions. This is just a couple things. I call them the night of. I make sure they're okay. We see them that following Monday. Most of these cases are on Fridays. We check the occlusion, make sure there's no destructive forces, make sure they're very clear on what they need to do. And this is beautiful photos. Again, thanks to Dr. Michael Chapman for providing me these. 1 month post-op, you can see healthy soft tissue. You can see the cleansability underneath the prosthetic. You can see nice, healthy pink tissue. And most importantly, look at that crestal bone maintenance. That is a thing of beauty. That platform switch, the aggressive thread design, you can see where I did my transalveolar suturing here. These little holes is where I cinched down the soft tissue to get a good keratinized tissue positioning and a good result. I'm very excited to see him 3 months from now and excited to upload the final prosthetic. So we've had the opportunity to change many lives, convert many smiles, give people the smiles they want and deserve. And I'm very appreciative to all the folks at ZimV who gave me the opportunity.
Thank you so much, Dr. Singh. That was a really great case and really great presentation. Appreciate you sharing. Yes, we did have some questions come in, so let's get to those, shall we? Let's see. The first question I have is, how do you manage antibiotic prophylaxis?
Yes. So obviously patient dependent. So American Heart Association and the ACA came out with firm guidelines for folks with prosthetic valves, unrepaired heart defects, folks that have unrepaired or repaired heart defects. Those need to be prophylaxed. The orthopedic literature as well as the ADA came out with firm guidelines that you do not need to pre-medicate for joint replacements. That being said, if the orthopedic surgeon mandates it and the patient mandates it, I don't fight that. But to answer your question, all the literature, as surgeons know, support the fact that preoperative antibiotics administered 1 hour prior to surgery have the greatest benefit. And in the interest of antibiotic stewardship, you want to responsibly prescribe antibiotics. So, at bare minimum, my patients very cheaply and very easily get either 600 milligrams clindamycin that they'll take with a small sip of water while they're NPO for their sedation for surgery, or 2 grams of amoxicillin, or if they're allergic, the first of a Z-Pack, or in worst case scenarios, Keflex, things of that nature. So we do prophylax these patients for these big cases, and I do prophylax them for any extensive bone grafting, which keep an eye out for in July. I'll be giving a webinar on complex bone grafting.
All right, awesome, thank you. Next we have, you mentioned heating the bone over 47 degrees will permanently affect the bone. Based on this, would you recommend the use of internal irrigation drills more than non-internal irrigation drills?
I do recommend internal irrigation drills, but I also recommend a pumping motion. Do not leave your drill in the osteotomy. Oftentimes, D1 bone is great, but it's very dense. So the tendency is to push, push, push to try to gain that depth in the bone. Utilize sequentially in larger osteotomy. Use a pumping motion. Make sure your RPM on your implant drill match the type of bone. So if I have D4 bone, I'm not zipping osteotomies at 1100 Newton centimeters. I'm doing it 800, 900 Newton centimeters. If I have D1 very dense bone or someone that has very minimal trabecular bone, I'm getting up into 1100, 1200. Constant internal irrigation, constant movement of the drills. And with the TSX implant in particular, you can skip the step drills. So you're not having to really use all the drills. So using less drills also prevents that from happening.
Okay,
And I'll
great, thank
also add, I apologize. I also add, a lot of folks are utilizing digital workflows, and I'm all for that. One of the things I like about Rowe Dental Labs as compared to other laboratories, their Chrome guided smile has kind of a metal sleeve to it where you can internally as well as externally irrigate. A lot of these implant guided companies have like a very bulky acrylic prosthetic with metal sleeves. There's no way that a drill that is hugging the metal sleeve is getting irrigated internally. So in those particular cases, you want to take advantage of external irrigation. You want to be in and out quickly.
All right, awesome, thank you. We just got another question coming in, and it says, Dr. Singh, thank you for the lecture. Did you consider reconstructing the defect of your last patient with the mandible fracture, either with
Anterior
AICBE
crest bone graft or
or
so this
even,
yeah,
sorry,
good.
go ahead,
Go ahead.
or even the new Rios titanium mesh with
Mhm.
a mix of allograft, xenograft?
Yeah, so in that particular case, I was actually able to achieve a good reduction. I'll pull this slide up real fast. Brad, if you can flip it back over, I'll pull that
Oh,
slide up,
sure. Yep.
just so you can see the reduction that was achieved. When I reduced that fracture, there was a pretty sizable and appreciable reduction of that fracture. So what you're seeing in that rate, this is the
You're,
fracture line right here.
you're
Um,
good to You gotta share it.
Yeah, you got it. Yeah. Can you see it?
Yeah, we're good. Yep.
Okay. So, in this slide right here, you can see that this is the fracture line here. And so we were able to reduce it. So a lot of what you're seeing on that radiograph is on the lingual aspect. We had firm cortical to cortical contact at the inferior border as well as facially. So in this particular instance, I didn't feel the need to create a donor site morbidity and a prolonged recovery for an anterior iliac crest bone graft. I also, using Rios and sticky bone and things like that, the complication there was that orocutaneous fistula, right? So all of this was done extra orally because the patient already had the incision, and I didn't want to compromise my advancement flap where I closed the soft tissue pedicle. And so you can see right there that is closed, that was open. So in order to adapt and place a mesh here, I'd be cutting through scar tissue. All of this is scar tissue from the initial surgery. You have to keep in mind this is the third surgery this patient had. And so I would have hesitation going intraorally, adapting a titanium mesh. I'd be afraid of mesh exposure. I'd be afraid of reintroducing an oreocutaneous fistula. So in this particular case, I was comfortable with the amount of reduction. And as I mentioned, we waited about 6 months. I don't treat radiographs, I treat patients. And so I had no concern. The mandible was stable. It wasn't going anywhere. His bite was stable. He had no mobility across the fracture line. He had no infection. So I was comfortable proceeding as is. But I have had continuity defect cases. If you tune into my July presentation, I'll show a case where I did a resection and a posterior iliac crest bone graft, and I'll be placing implants coming up here soon on that.
All right, awesome. That was actually the last question.
Beautiful.
Just a lot of comments, just to let you know, all saying how great the presentation was. So, really great presentation. Thank you so much. Really enjoyed it. Look forward to seeing the outcome of this in 3 months. Maybe we can do an update on one of your next ones you
Absolutely.
do with me.
Be
And
happy to.
then congratulations on the new addition to your family.
Thank
And
you very much.
Yep, absolutely. Can't wait to have you back. Thank you again. Great presentation.
Thank you, everybody, for tuning in, and thanks again to Zimvi for the support.
We thank you everyone for joining us this evening. Next Tuesday, the 16th of May, we have Dr. Ushma Patel on her rebroadcast ZI live case presentations on her topic entitled Implant Treatment Planning from 1 to Full Arch. You may scan the QR code on the screen now for more information regarding this lecture and to register. We have put out on our screen now the QR code for Zimvi Education's app. Simply point your smartphone camera to the screen and a link will pop up for you to click on to bring you to the App Store to download the app. In the app, we put our live webcast on-demand courses for you to choose from to attend. We will leave the QR code off for a little while for you to do so. We thank you once again for being with us. Till our next course, stay safe and take care.